Okay, I'm going to be talking to you today about hip dysplasia. So, we'll start off with a definition. Um, hip dysplasia, otherwise known as developmental dysplasia of the hip, further to referred to as DDH, is a pathological anatomy of the femoroacetabular joint, aka the ball and socket hip joint, that is caused by reduced acetabulum femoral head contact. So what that means, as you see here on the left, is a normal socket. The acetabulum really cups the femoral head pretty well. So as the femur moves around, it stays in contact with the acetabulum and is pretty well supported. It can't slide sideways. Now, as you see on the right, that's an example of a shallow socket. So that is a form of hip dysplasia. And what can happen here is the hip, as the person moves their leg, the femur actually slides up and down and all around. It's a very unstable situation and can lead to easy hip dislocation. It can also actually cause the femur head to completely leave the acetabulum, and it can cause dislocations, problematic dislocations. Another version of hip dysplasia is when, rather than the acetabulum being malformed, it is the head of the femur that is malformed. And again, even though the acetabulum is perfect, the head of the femur just doesn't quite work. Moves around a bunch, can fall out, and what big problem with either of these pathological situations is that you end up with a lot more rubbing than would normally occur, and this damages the cartilage and can lead to early osteoporosis. And pain, and is just generally very unpleasant. So the epidemiology of hip dysplasia, developmental hip dysplasia, is difficult to say for sure, simply because a lot of doctors don't really agree on what counts as hip dysplasia. There are many different types of hip disorders, and some doctors diagnose many things as hip dysplasia, and some are very specific in their diagnosis. So what we think is that hip dysplasia tends to be overwhelmingly female. 75% of hip dysplasia cases are female, and only 25% present in males. Just we assume due to the female morphology. The likelihood of a baby having developmental hip dysplasia is much higher if they have a family history, especially if they are the daughter of a father that has hip dysplasia. It is also higher if the baby is born during the winter, and the thought process behind this is that it is caused by swaddling, which often has the baby's legs folded up and then wrapped in tight fabric to keep the baby warm, and this pushes the hips into a bad movement pattern and causes damage when the baby's bones are still soft. It is also 6.3 times more likely to find hip dysplasia in babies that were in a breech birth position. So what a breech birth position is, this is examples of them. A complete breech has the baby with the legs crossed, whereas a frank breech, the baby has his legs almost straight with his toes up in front of his face. A frank breech is actually much more likely of the two to have hip dysplasia. Many times when the baby is in a breeching position, meaning that their bottom is coming out first rather than the head during a normal vaginal birth, the doctor actually recommends a cesarean section for safety of both mother and baby. And even if the baby is delivered via cesarean section, if they were in a breech position presentation for the birth position, they are still more likely to have a hip dysplasia than a baby that is in a normal presentation and is also C-section. So, to diagnose hip dysplasia, you really need hip radiography. The doctor will usually, you'll go to a doctor and say, pain in the groin and hip, and then they'll recommend a hip radiograph, and then look at that, and they'll be able to see any bone misshapenness, and then they will diagnose the hip dysplasia. Now, there's a variety of treatments for hip dysplasia depending on the severity and how early it's caught. If the person is overweight, one of the first things we say is make lifestyle changes, lose weight, because losing 5 pounds decreases the weight on the hip, the pressure on the hip, the force on the hip by about 15 pounds. So we very obviously want less pressure on the hip if it is having problems and causing pain. So first thing we're going to do is say lose weight if the person is overweight. Many doctors will recommend physical therapy if that is an option. If the person has severe hip dysplasia or already is displaying damage due to their hip dysplasia, they may be recommended to get periacetabular osteotomy or hip preservation surgery. If the person has severe damage, they might be recommended to just get a full hip replacement. Now, we happen to live in an area that is home to one of the world's premier hip replacement surgeons. He does the anterior approach hip replacement surgery and is actually the surgeon that most other surgeons come to learn how to do this anterior approach. The healing time is so much quicker. The person is up the same day as the surgery and is walking the next day. So if your option is get the hip replacement surgery, go through recovery, or have severe pain in your daily life, we highly recommend the hip replacement surgery. It is definitely one of the surgeries that is much better than it used to be. So, all right. So my case study for this is a 25-year-old female. She presents with hip dysplasia in her left hip and has a history of hip dislocation in the affected hip. She has been going for bike rides most weekends for a few months now and is obese. She also has a doctor's note encouraging activity. And post her so the last hip dislocation that she suffered from was worse than her previous ones. Her first, she usually would have a dislocation and then was able to pop the hip back in after a few minutes. But this particular one, it stayed dislocated for hours, and she actually had to go to the emergency room and get her hip put back in properly. So after that, she had physical therapy. So we need to take that into account. So our exercise recommendations for this patient include low impact exercise. She is obese. We would like her to lose weight. She can follow ACSM recommendations, which is 150 minutes a week of moderate intensity exercise. We just want her to really keep an eye on her hip and emphasize low impact activities. We'd also like her to engage in some hip strengthening activities. A really good exercise for this is doing clamshells, which is the patient lies on their side and then they bend their knees and keeping their feet together, side by side on top of each other, they separate their knees like a clamshell. If that is very easy for the person, they can put a weighted band between their knees and do it that way. And that will strengthen the muscles that help hold the femur's head in the acetabulum. So, and we definitely don't want to encourage stretching of the hip, just because we kind of want those muscles to tighten and help hold the femur's head more against the acetabulum, especially as the patient has a history of hip dislocation. So we recommend walking a few minutes a day as much as you can. We can recommend swimming. We might recommend using an elliptical. This particular patient said that running actually hurts, so obviously we do not recommend running. The problem with strength training with this particular individual is a lot of strength training requires bending at the hip. And at her current status, I think that would be far too dangerous. So we do not recommend squats or anything like that until she has more hip strength and we have a specific note from her doctor saying that she is cleared to do weight training activities involving her lower body. So, right? And then here are my references. Okay. And that's it. That was my presentation on hip dysplasia. Please let me know if you have any questions.